We are live.
Am I audible now? Because apparently I was muted.
Yes, sir. Loud and clear, sir.
Yes.
Thank you. So, a very good evening, everyone. And my apologies for beginning late for the first time. I ensure that it won't happen again. And thank you, everyone, for joining in. And welcome to the next subspecialty series, where we'll be talking about insights of myopia control from study to clinics. As you all know, that last week was the International Myopia Awareness Week. And hence, we have this program with the galaxy of speakers from our state as well as nationally. And if our moderator, can you play the presentation, please? I'd just like to introduce quickly our speakers, panel, and moderators. So, beginning with our first speaker for the evening, we have Professor Dr. Rohit Saxena. He of course needs no introduction. He's Professor of Pediatric Ophthalmology, Strabismus Neuro-Ophthalmology at RP Center, AIMS in New Delhi. We've had a long association with him. Of course, he is one of the most widely published author that is there today. He's invited faculty for n number of conferences, regularly conducting instruction courses and performing live surgery, teacher par excellence, with more than 35 international and national awards to his credit. He's trained a lot of PG students and has tremendous amount of work in myopia. Abhilasha, can you? Yes. We have Dr. Jitendra Jethani from Baroda, who, of course, we all know to be a prolific surgeon, apart from his great work in myopia control, especially pre-myopia. And he's now pursuing a PhD in myopia as well. Now, apart from his clinical work, he's also into a lot of key positions and organizational associations, like he has served as the secretary and president of the Baroda Ophthalmic Society. The list keeps going on and on. As scientific committee chairman of the Gujarat Ophthalmic Society, he's won a good number of awards in AIOS, as well as travel awards and SPOCI awards, and the AGOS awards, that is the All Gujarat Ophthalmic Society awards. He's extremely well published with 67 peer-reviewed articles, as well as gold medals to his credit from the IRSI. So it's very nice to have Dr. Jitendra. We have Dr. Siddharth Kesarwani. Of course, I have a very special association with Dr. Siddharth Kesarwani as well. Before I go on to tell you about him, he's an IR alumni, of course. But my first interaction with Dr. Siddharth Kesarwani was when, as a resident, I was attending his lecture. And there are very few speakers and teachers that you come across who have a knack to, make topics very simple and interesting. So he is one of those teachers and speakers, apart from being a prolific surgeon. And now he is a alumni of Bangalore Medical College and Nair, like I just said. He also founded the Miriam Haiman Children Eye Care Center at LV Prasad Eye Institute in Bhubaneswar, and he was the head of it for many years. He's, of course, proficient in the diagnosis and management of all childhood eye diseases. I know him to be a Gandhivadian, and whenever I feel that, my ethics perhaps need correction, probably he's the one person that can bring me on the right track. He currently runs the JNR Eye Clinic at Borivali in Mumbai. And of course, like our previous speakers, he's extremely well published and has served on the board of the Indian Journal of Ophthalmology and reviewer for several other journals. His publications on surgical techniques are well documented and extremely helpful for a lot of other surgeons as well. Uh, Thank you, Abhilasha. We have Dr. Abhilasha Parkhe, who's a consultant in pediatric ophthalmology and neuro-ophthalmology at HV Desai Eye Hospital in Pune, an alumni of BJ Government Medical College in Pune. She completed her pediatric ophthalmology training at NN Bangalore with Dr. Jyoti Matalia, who unfortunately couldn't be with us today, even though we did wanted to be there. She was going to be in Indore. And further to this, then she completed international fellowships at John Hopkins as well as Wills Eye. She's well awarded at in Pune Ophthalmic Society, at the Maharashtra Ophthalmic Society, with keen interest in community ophthalmology. And of course, her another core interest of hers is neuro-ophthalmology. She'll be moderating the session today. Thank you, Bilasha. Can you we have a very senior pediatric ophthalmologist, a general ophthalmologist, Dr. Shubhangi Bhargadas, who will be on our expert panel today. She's an alumni of GMC Nagpur. Uh, she was the president of the Nagpur Academy of Ophthalmology way back in 96 and 97, even though she doesn't look the senior that she is. And the approachability that Madam has is absolutely phenomenal. She served as the president of the VUS, that is the Vidarbha Ophthalmic Society. It's a very old society, which is a part of Maharashtra. And she served as the scientific committee chairman of VUS, and she was a member of the scientific committee of Maharashtra Ophthalmic Society. Madam is practicing at Drishti Eye Clinic and Squint Center since 1994. And she's also served as the president of SPOCI, which is the Strabismus and Pediatric Ophthalmological Society of India, in 23 and 24. So it's very nice to have Madam over here. We have another very prolific surgeon who doesn't look her age and her seniority, Dr. Sujata Chahande. She's professor and head of department at Grant Government Medical College and JJ Hospital in Mumbai. And there are so many awards that are credited to Madam. A few of them probably I can enumerate. She was awarded the National Leadership Award in the health sector in 2016. The Adarsh Seva Puraskar, which she held since 2018 till date. In 24. She has won the iWiki contest and awarded Main Hoon Beti Award in 2019. She was the winner of the first Lokmat Dog Walk Mrs. Medico 2019 title, and a winner of the Lokmat Women's Achievers of Pune, which we're very proud of in 2020. She was also the winner of the first WOS Queen pageant, as well as many other pageants to her credit. And she's completed her pediatric ophthalmology training at Pune, and again, very widely published since the last 20 years. She's been conducting hands-on programs and instruction courses. So it's very nice to have Madam along with us. We have Dr. Prachi Agashe, madam, who's the medical director at Agashe Hospital in Mumbai. She's also a consultant pediatric ophthalmologist at Agarwal Eye Hospital in Navi Mumbai, as well as a teaching hospital, KB Haji Bachuwali Hospital in Parel, as well as Surya Child Care in Santa Cruz. Madam has completed her fellowship from Arvind Eye Hospital in Madurai, as well as training in retinopathy of prematurity at world-renowned L.V. Prasad Eye Institute, as well as having worked with Dr. Richard Hurtle. So it's very nice to have Madam over here along with us, and we look forward to her inputs regarding this. Apart from this, she's been awarded gold medals for best paper in the SPOCI conferences, as well as she's a faculty at BOA, at MOS, at AIS conferences since 2014, as well as taking out time and serving as a managing committee member at the Bombay Ophthalmic Association. So welcome, madam. We have Dr. Rishikesh Mahi, my dear senior colleague from Nagpur, who's the director of Avadut Netralaya. And there is so much to speak about him, but we're going to keep it short because we're running a little late. And he's, of course, an alumni of Sankar Netralaya in Chennai. He's won n number of awards, including Best Poster Presentation at AIFC, at Bombay Ophthalmic Association, the Dr. Sutaria Runner-Up Award at WOSCON. I mean, the list goes on and on. He's got a number of publications in various journals and research papers. And of course, his areas of interest are strabismus, myopia management in children, and visual rehabilitation of children. So we look forward to getting inputs from Dr. Rishikesh Mahi. We have two exceptional moderators. Dr. Prasad Barimbe, sir, is my dear colleague in Pune. We get the opportunity to tackle patients together many a times in Pune. So briefly about Dr. Varimbe. He's an alumni of, again, the prestigious BJ Medical College of Pune, after which he joined the Arvind Eye Hospital in Madurai as a senior fellow way back in 96. And he worked as a senior medical officer at Tirunelveli, where he was also instrumental, essentially, establishing the Department of Pediatric Ophthalmology and Strabismus under the guidance of Professor Vijayalakshmi. So after his spending his time at Arvind Eye, he then went on to Wisconsin in the University of Wisconsin in Madison in the US of A, under the guidance of Dr. Kushner. And he has extensive experience in community outreach programs. He was a faculty member of LICO. He was a member of the World Bank team, which was involved in the midterm assessment of cataract blindness control programs in India. He's also worked with site savers. So, I mean, there is just so much to him more than ophthalmology itself. But we'll stick to a few things over here. So, apart from his work in ophthalmology, he's also was instrumental in promoting AIDS awareness and prevention programs in Maharashtra. He's a widely published author. He's actively participated in national, international conferences where he's always invited as his invite faculty. He's written and edited books, including Step-by-Step Squint Surgery, which was published in 2011. And he's currently practicing pediatric ophthalm, of course, at multiple hospitals, including his own. He at Deennath Mangeshkar Hospital and Jahangir Hospital, where we have the opportunity to work together. So thank you, Dr. Varimbe sir, to uh, be over here and conduct the program with Abhilasha. So over on to Abil. So give me 1 second.
Yeah,
I just want to see if Dr. Shirish Thorat sir is there.
please go ahead.
So,
You're already late.
so handing it over to Dr. Varimbe and Abhilasha for moderation of this session, this very important session on
Yeah.
myopia.
Yeah. Good evening, everyone. Welcome to this wonderful session on insights of myopia control from study to clinics. We are already 5 minutes behind the schedule, so without wasting much time, I'd request Professor Dr. Rohit Saxena to start his topic on childhood myopia, an epidemic we can slow, and role of lifestyle modifications. Over to Professor Saxena.
Thank you, Piyush, for the opportunity. Thank you, MOS, for the wonderful topic that we are covering. It's definitely very, very important and probably a very current thing that we need to actually discuss. Uh, is my slide visible?
Yes, sir. We just need to go
Okay.
into full screen mode.
It's in the full screen. Is it now or not?
Yes, sir. Thank you.
Okay, great. So, I'll be essentially talking on childhood myopia, and the topic was quite a bit of a mouthful, so I've kind of just reduced it to slowing the epidemic that we are seeing of childhood myopia, essentially because the key intervention has to be lifestyle modification, and I'll tell you what we are actually talking about and why we are discussing this. So the first question, as ophthalmologists and to any general public I talk to, or parents or caregivers of children, the first question really is it really such a big problem? This was not really understood fairly well about 10 or 15 years ago, when a small group of us, many of who are on this session today, were actually started talking about myopia. But this paper here actually made the world sit up and take notice. Although the kind of prediction that it has made is on not very solid ground, but there is no doubt anymore that we are going to hit the prediction that it is saying, or maybe even cross it. So, this paper predicted that by 2050, 50% of the world's population is going to become myopic, and 10% of those are going to be high myopes, which is a pretty major concern. But again, as I mentioned, about a decade or a couple of decades ago, this was not really a cause for concern in India. We were reading about stray reports of high myopia in East Asia, but none of us was seriously thinking that it's a major cause for concern. Now, I'll tell you why we missed it, or that that this mistake happened, that we actually didn't pick it up. Now, this was just one of our papers, and this data actually made us sit up because in 2001, a survey done from RP Center showed a myopia prevalence in a region in Delhi of 7.1%. And in 2014, when we revisited that, although with a little modified protocol, it had jumped to 13 plus percentage, nearly doubling it, really, if you actually look at it. The other thing was that Indians are not really immune. This was a very interesting study that was done among Singaporean Indians, and in fact a lot of others, but I just picked out the Indian data for this. And it said that the first generation immigrants from India had about 12 to 14% of myopia, which is kind of average for an urban, affluent, aspirant group of people. But the second generation, their children, the myopia jumped to 28%. So it's not only that we are not immune to it, but there is definite evidence that we are fairly susceptible, and it is becoming a cause for concern. The next thought is that, after all, myopia is just a benign disorder. Now, all you need to do is give a pair of glasses. I mean, what's a big deal in that? Yes, we need to screen, but first problem is that it's difficult to detect in children. And the problems of uncorrected childhood myopia would be strabismus, amblyopia, retarded learning ability. These children who do poorly in school and sports often suffer injuries, a lot of effect on their physical, emotional, and social functioning. And this will, in the long term, result in poorer education, loss of employment opportunities, economic loss, and impaired quality of life. And this is not talking about even the medical issues related to myopia, particularly high myopia, when you see pathological myopia and the huge risk that these patients have of getting blindness, which is irreversible. Now, again, as I mentioned, our thoughts are that, spectacles are pretty cheap. Do we really need to, really concern about all of this? And why are we talking so much? Now, uncorrected refractive error in a major part of the world, including in the western part of, in the western hemisphere, is a significant problem. This is 4.6 billion is the cost of specs in US alone, and this is pretty dated results that I'm actually quoting. Add to the cost of all the problems I talked about, the loss of productivity, the treatment of comorbidities. The estimate is that the global loss of GDP because of myopia in 2004 was 268 billion, or when you add the other problems also, close to $300 billion, which I'm sure now makes us think that it is not such a cheap problem. Now, when we talk about how we can prevent it from happening in the future, how can we prevent this progression? So we need to understand the concepts behind myopia. The initial part of myopia epidemic that it started, there was a way in between whether it's nature or nurture. So whether it's the genes that is making us myopic or it's the environment. Now, in the past 50 years, we have seen that across the world, across any nation, any racial group, any region, myopia has significantly increased in prevalence. However, we know that past 50 years is hardly any significant time for the genetic makeup of a population to change. So it is obviously the environment, and particularly the changes in school training, reduced outdoors hours, urbanization, a lot of near work reading hours, and a reduction in the ambient light because you're staying indoors most of the time. And it is tackling these risk factors that is essential if we want to prevent this myopia from running away from us. Some are of these risk factors, some are, of course, not much we can do about, but some are definitely be modifiable. So, girls are more prone to be myopic as compared to boys. Parental myopia, if the parents are myopic, three times the risk if both the parents are myopic. Strained visual environment where they are reading and writing or near activity for long continuous hours, particularly close. Urban areas is far more, particularly possibly because of constricted living spaces and the idea that there is no horizon that we ever see in cities. We are always in constricted living spaces. Higher education, private schools, which is an Indian concept, high monthly income. So these are all the urban, affluent, inspirational group of people where we are seeing a significant rise of myopia. And the only real risk factor modifiable is outdoor activity. And it's generally seen that about 2 hours or more of outdoor activity or just outdoor presence during light or daytime, daylight hours may be fairly protective. Age is the important thing because younger the child when the myopia starts, longer is he at risk. And of course, tougher it is to treat. It is poorer therapy. Younger the child, the outcomes of therapy is definitely poorer. Again, as I mentioned, girls, it probably may be that they spend less time outdoors, but that's of course something that can be discussed in some other time. Parental myopia I talked about is very, very important. The parents who are myopic, even one, it's important to be very highly sensitive about your children's eyes and their vision. And anytime you feel there is an issue, these children must be evaluated. The most important influence we can do is lifestyle modification. And remember, myopia is the youngest lifestyle disease to affect humans. When we talk about lifestyle diseases, we talk about diabetes, hypertension, and we say that lifestyle modification is must. Similarly, unless we recognize that myopia is a lifestyle disease, we do not lay the stress on reducing the near work and decreasing screen time, ensuring or encouraging frequent breaks, the 20-20-20 rule of APOS or APAO, increasing the ambient illumination, particularly indoors. So you need to have a lot of outside light streaming into your room or in classes where children are studying, maximizing the natural light availability. And of course, correct the posture, appropriate reading distances when they work on a table chair where they can ensure an arm's length distance to any digital activity, or of course, preferably any games or anything children are playing should be done on a television. So visual environment is the major contributor. We've talked about outdoor activity, which is the most important thing associated with prevention or reducing the rate of myopia incidence. And there has been fair amount of understanding that it may also help in reducing the rate of progression. And higher odds of becoming myope are sustained near work continuously for more than 45 minutes, close distances, and almost 2% increased risk for every one dioptric hour of near work per week. So these are important things. Heavy educational curriculum. We've all been through the grind, and we know our children are really at a worse place than us. They hardly have opportunity to go out with the school homeworks and the tuitions we are putting them through. And these are all areas which have been shown to be strongly associated with myopia. Now, I'm not saying that our children should be duds, but then there has to be a good balance between academic activity, the distance at which they are doing near work, and outdoor opportunity. And this, of course, is the most important thing. And a lot of studies have shown that there is a definite impact in the incidence and progression of myopia of adequate outdoor activity. This is just one of the studies that was done in China. They just locked the classroom during recess, which kind of added a 40-minute outdoor activity, or in another study, added 40-minute outdoor activity. And they had shown that there is significant reduction in the progression, in the development and progression of myopia in these children. And this is what you can see, the increased prevalence of myopia is kind of running very much in parallel with the results and the scores and the educational qualifications of people. And in Australia, you see a lot of outdoor activity, and you can see that the increase in the prevalence has not followed that. So this epidemic in East and Southeast Asia, which is paralleling the increase in the educational pressures and the educational knowledge, is probably something that is now affecting India also with the high educational pressures, and we need to be very careful about it. It's important to primarily prevent, which is prevent development of myopia by involving or intervening at school levels to improve the lifestyle and to bring about a change. The secondary prevention is to identify children with myopia, give them spectacles so that they see better and they develop better, and prevent myopia progression by either lifestyle modifications or many of the interventions that are going to be discussed later in this program. And of course, tertiary prevention, where you prevent the blindness due to myopia by identifying those at risk and regularly following them. So it's important to increase outdoor activity, decrease or control their near work, and of course, possible progression or even incidents may be managed by medicine. So it's important that all I see, and it's necessary for all of us together to create a mission mode to ensure spectacle coverage and preventing progression of childhood myopia. Thank you very much for the opportunity.
Thank you so much, Dr. Rohit Saxena, for the wonderful talk. So the whole purpose of arranging this talk was that regardless of the location, whether it's urban or rural, the myopia control management should be equal in urban settings and rural settings as well. And I think Dr. Rohit Saxena is the best person because he has worked already on both the settings and he is the best person to comment on that. So thank you so much. I would request everybody to put queries or ask panelists if they have any comment on this or ask questions. Till that time, I have one question for Dr. Saxena. That is outdoor activity equally effective for pre-myopes? That is, whether it is preventing the myopia or after the onset of myopia, also it is equally effective.
There is very hard evidence that incidence of myopia is definitely prevented or reduced, or the incidence of myopia is definitely impacted. The question on progression of myopia is still not absolutely clear, or very hard evidence. It's still some studies have shown an equivocal result. And the thought behind it is that there is some minimum amount of hours in adequate ambient illumination that children must spend before that effect of preventing myopia progression can happen. So most studies have said about 2 hours a day or about 14 hours a week in adequate daylight hours. But as I mentioned, preventing progression is not as obvious or as effective as preventing incidences, but still it is pretty clear that lifestyle modification, even to prevent progression, is a must add for any intervention program you are giving to a child to prevent progressive myopia.
Yeah, one more question for Professor Saxena. Have you found any difference between rural and urban children as far as the myopia incidence and prevalence is concerned, and as well as the effect of interventions on the myopia progression in rural vis-a-vis urban?
Thank you, Dr. Valambe, for this question. It's something that I actually was regretting not having discussed adequately in my presentation. It was something that that we used to, as a group, feel that rural myopia is really not something to worry so much about. But I couldn't take you through one of our papers which we had done, where we had taken 40 years of all the studies accumulated together, and the most unfortunate finding of that was that rural myopia was increasing at a much higher rate than urban myopia, although the prevalence was much less, almost a third, compared to the urban area, but the rate of increase of the myopia prevalence was much higher in rural as compared to urban, possibly now because of a greater digital access now these children have. So it is now an increasingly important rural problem, and we are seeing that there is significant myopia now in rural children also, contrary to what one would have believed, that they do spend a lot of time outdoors. But as far as intervention effectivity is concerned, at the moment, I don't think there is any clear study that can give us that there should be any difference. We just hope that rural children should respond better, because I always feel that for any treatment for myopia to be effective, you need to add lifestyle modification. And hopefully the children are able to. In cities, I feel that most of our children are unable to go out. I mean, you tell them to go out, but there are no there are no parks, there are no areas where children can go. So it's a very, very big challenge for them. In rural areas, at least we expect and hope that they have the opportunity to spend time outdoors. So I hope it would be more effective. But yes, it is a cause for concern in the rural area also.
Thank you, sir. Thank you, sir. And
Thank
one
you.
more question to our expert panelist, Dr. Bhave, madam. You have seen generations of people with myopia, maybe their kids also. So have you found any cross, change from the normal in the coming generations? Because you must have seen their grandfather, grandmother, the father, mother, and the children. So have you found any gross deviations or any changes as far as the myopia epidemic is concerned?
Yeah.
Is it?
Basically, we are seeing an increased incidence of myopia in recent years, last 8-10 years, more so after COVID. And
Yeah.
even the first time number which the patients are coming with are pretty high, -3, -4, which was may not be, it wouldn't have happened if they were not restricted to their screens.
Yeah.
So they would have noticed it earlier. So because like since COVID, I think the world is just restricted to their mobile screens, and so the diagnosis is pretty late sometimes. And of course, there is a increasing shift in myopia. And just one more comment to what Dr. Rohit was saying regarding the lifestyle modification. I counsel a lot of kids who come to me regarding the sunlight or outdoor activity, but then they don't have time. So they say that we don't have time. I said, then in the school you should go out in the recess. But then some schools nowadays probably don't have a lot of place. So they tell me that in the recess, they lock the classroom and they're with the kids inside. So they're not allowed to go out in the recess. So I think it is, as a society or as pediatric ophthalmologist, it is even our responsibility to make the awareness in the schools that it is important for the kids to go out, because the school timings are such that they don't get exposure to sunlight, and even if they don't get it in the recess, then it is very sad.
I would just
After
like to
this
add
question-
something. I would just
Yes,
like
yes,
to add
ma'am.
something. We were talking about the lifestyle changes. I think what needs to be done is one needs to change the lifestyle for the parents and the teachers more than the children, because finally they follow what we adults expect them to do. A very nice move very recently that I read is Sweden. They have come up with this, that they want to get the screen time less from the surveys and studies that they found out. So now they have gone back to the books. I mean, the screen is not, they are not having activities to do with the screen now. They're going to implement the textbooks, the books, the notebooks, and the paper and the pen is what they are going back to. So old is gold. Yes, I think we should resort to that. AI is there to help us, but we shouldn't forget. Plus, even the fine motor skills kids are losing upon. So I think for intellectual development and all in all, we need to make a good balance between both the things, the modern and the old ones.
Yeah, I think the discussion can go on and on, but we have other speakers to speak. So I would request Dr. Jitendra Jethani to speak on the pre-myopia. Over to Dr. Jitendra, please.
Sure. I will share the screen. Yeah. Is it visible? Audible?
Yes.
Yes, sir.
Yes, sir.
Great. So I think what I'm just continuing what Professor Dr. Rohit sir has said. I think it is an important part of the myopia control to catch them young, to catch them early when there is an early window of opportunity to hold these patients, to find out those susceptible groups which can be prevented from going towards the path of myopia. So I would just enumerate some of the points, some of the issues in premyopia. And what exactly is premyopia is that it is the refractive state. So it is not truly those patients who are yet to be myope, or they are very minimally myope and they have a risk of progression. So the whole premise of premyopia is based on the fact that these are the patients who have a risk of progressing to myopia. So only those patients who would be definitely, or who have some scoring risk factor or something like that, can only be called as pre-myopes, and not all the patients who have a plus 0.5 or some refractive error would be called it as pre-myopes. So why there is a range of plus 0.75 to minus 0.5 is because this range encompasses the age at which these particular refractive state makes them susceptible to go towards myopia. So it's a refractive state which is between plus 0.75 to minus 0.5. And it is obviously a combination of baseline refraction, what is the age, and other risk factors that we will see, which actually provides a sufficient likelihood that these are the group of patients who may develop myopia in the future. So what is known in premyopia is that, the baseline power is one of the most important risk factors, and baseline age. When correlating baseline power with age, that makes it, this particular patient would be more susceptible, and we will see what are the ranges. And another important risk factor is parental myopia, which we had elaborate discussion just now on whether, if parents are myopic, what are the chances that kids would become myopic. So the cutoff for predictive myopia by the age of 13. By the age of 6, it is plus 0.5. By the age of 7 to 8, it is plus 0.75, 0.5, and it goes on and on. So this is one of the, I've just taken a screen recording of Bran Holden Vision Institute myopia calculator, and this is there on their website. You can go and check for each and every patient. You can go into the refractive state, what is the power, and then if you see this calculator more closely, you would feel that age is a risk factor, the baseline power is a risk factor, and overall, if you see clearly, it is the parental myopia which makes it. If parental myopia is none, see right now the parent myopia is none, and if the refractive error is on a plus side, that is known as hyperopic reserve, there is hardly any risk factor. And if you change two parents none, it doesn't change anything. So it is baseline refractive error which is more important than parental myopia. Now you change the refractive error to plus 0.5 and it will become significantly higher. Now, if you change it to E-metrop or 0, it becomes even more significant if the age is 6 years. So likewise, you can calculate a scoring system and you can see the probability of becoming myope within 1 or 2 years and 2-year probability. So this is a good quantifiable scoring system. And I think this is not really for Indian population. And we are doing our own validation for some of the studies. And another scoring factor, I think, is this is another great paper. And what they found was the two major risk factors were cycloplegic refraction and axial length, and they were correlated with the age. Now, coming from this particular article, they made a scoring system as to what should be the scoring system for a particular patient, whether that particular patient will go into myopia in another 1 year or another 2 year. And all these things, major thing is spherical equivalent at presentation, age, and myopic parent, whether the patient has myopic parent or not. And again, what is the baseline axial length? And what is the antechamber depth or K reading? So this is the ACAL upon CR ratio, axial length upon corneal curvature radius ratio. So taking all these factors into consideration, the NICER study has made a scoring system to predict myopia onset and its progression. So what they have done is they have divided children into two groups. One is 6 to 8-year-old children, and they have made a separate scoring system for that, and 9 to 10-year children, and they have made a separate scoring system for them. Now, what is this? What is the significant score? That also they have, they have said if there is a scoring system of between 1 to 3, there is very low risk, and between 4 to 6 is a moderate risk. So when the patient comes to you, yes, they have suggested that environmental and lifestyle advice. So yes, there is, as we were discussing, Abhilasha was asking whether, environmental and lifestyle advice would be equally effective in pre-myopes or not. At least these particular articles do suggest that there is some evidence. And at the end of the day, when your score system is so low, what else you can do? You can't start them on treatment because they are already on a low risk of developing or becoming myope, and they are likely to become myopic only by 16 years of age. So you can't treat these patients. You cannot treat patient based on scoring systems. So we will see which patients to treat. But the only thing you can do at this point of time is to do environmental and give them environmental and lifestyle advice. And you have to see what is the annual progression. So this is another. So the first part, table 1, is based on scoring system on the presentation. This particular thing is based on the risk of myopic progression. So age of the child and what is the annual progression in spherical equivalent. And then you can see that based on this also, they have got a little risk, moderate risk, or high risk. So this particular scoring system was, they tried to validate it, at least for UK population. And they found that a scoring system of 4 or more is strong predictive indicator of future myopia onset, particularly for UK children. We don't have right now Indian data. We have our own studies, but we have not come up with what is the preferable scoring system for Indian children to be likely to be myopic. This is just taking from the same study as the fact that any score more than 4 or 6 has a moderate risk to higher risk. And this is for the UK based population. Similarly, what we saw, what is hyperopic reserve? It is the amount of hyperopia that the child presents to you, and the amount of hyperopia with risk of myopia because of the various risk factors that we saw. So how much is enough? How much plus power is enough? Whether it is a refraction of plus 0.75, that depends on what age the kid is presenting, whether the kid has parental myopia, both the parents are myopic or not. What is the progression? How quickly the patient is losing his hyperopic reserve? So hyperopic reserve is a relatively new term which has come up, especially for management of myopia. And what is really truly his axial length versus corneal radius ratio, which if it is more than 3 or 3.2 is supposed to be significant. This is just to tell you the predicted risk of score in terms of age and for the hyperopic reserve. So with the hyperopic reserve of 0.75 plus 0.5 plus 0.25, 0 and minus 0.25, which is not truly a hyperopic reserve. And this was what we did in our clinic. We saw the patients, we scored them on Premyopia scoring system, and this is the correlation matrix of ocular parameters. And I want to credit one of our optoms, Devanshi, for this. So what we found was there was a strong positive correlation between hyperopic reserve at the baseline versus the follow-up, which means that obviously if there is a good hyperopic reserve, it is more difficult to lose that. Axial length does show a strong consistency from the baseline to the follow-up, and hyperopic reserve at baseline has a moderately negative correlation with axial length. Obviously, if the child is more on the hyperopic side, the axial length is supposed to be on the lower side, and this definitely suggests that this particular factor is strongly, or at least it is important protection against myopia development. So how to manage a premyope? All this is fine. We know what is the scoring system. So how to manage a premyope? Now we have to first of all find out that this particular patient has a risk of developing myopia. We already saw that. So what you do after that, you communicate with the parents regarding the fact that your kid is at a risk of developing myopia. Not that you start the treatment at that particular time. You can only start the treatment when there is definitive evidence that this particular patient is losing his hyperopic reserve very quickly and he is progressing towards myopia, and there is definitive evidence that this patient would definitely develop myopia. Now, you have to communicate this with fellow colleagues also, like we are doing at this point of time, because, if you tell the parents that your kid will develop myopia and patient is with you and is on the hyperopic side, it would be very difficult, your word against, against your fellow colleagues who have practically no idea what you are speaking about, because patient is actually hypermetropic and you are talking about the patient being pre-myopic. So what would you actually do is you will talk about lifestyle, you will talk about sitting outdoors, you will talk about doing less and less near work. At this point of time, if you are pretty sure that this particular patient is losing his hyperopic reserve quickly, you can go and in some of the patients we did start Atropine, and we published our data regarding that. Lifestyle modification plan is pretty simple. You have to tell them what this already has been covered nicely by Rohit sir. So what do you work up for premyopia? Essentially, what you do for myopes, you would do the baseline visual acuity, slit lamp examination, cycloplegic refraction, fundus examination, intraocular pressure, and importantly, you will do keratometry and axial length, because when you want to justify, when you want to say that this particular patient is actually progressing, there are only 3 factors which tell you this. One of them is cycloplegic refraction, second is axial length, and third is no change in keratometry or axial length upon CR ratio. There is an increase in axial length upon CR ratio, which shows that axial length is also progressing with relation to keratometry. Importantly, you can do open field autorefraction. Again, this is only to maintain the baseline. At this point of time, you're not planning to give them peripheral defocus lenses. Binocular vision assessment and all these things are important because you want to have the data, and when the patient is switching or when you see that this particular patient is going towards myopia, maybe you can start early compared to other people or compared to other patients. Now, whether there's a role of low concentration atropine in premyopia, there have been at least 3 to 4 studies. Fang et al. Did show that 0.025%. They started giving this in refraction of less than 1 diopter, and they found that it was quite good, and over 1 year 54% of control group progressed past -1 diopter, while only 21% did in the treatment group. Now, role of optical treatment, at this point of time, I personally do not have any experience with optical treatment for these particular patients. Yes, we did use low concentration atropine eye drops a couple of years back, and we did find that low concentration atropine does work in patients who are progressing beyond what we thought that they would progress, and these particular patients did have a better control compared to the control group, which was not using any drops. So based on our own experience, we have started classifying these patients into type 1 and type 2. Type 1, the only difference between type 1 and type 2 is that type 1 is with parental myopia, and type 2 doesn't have any parental myopia, because we feel that parental myopia is a very important risk factor, and type A will have one parent as myope and both parents as myopic, type B, type C, and type D. And type 2, none of the parents are myopic, but these patients are losing their hyperopic reserve much more quickly, and they have a history of, as Rohit sir said, a lot of urbanization, like high near work screen time, less outdoor activities. So type 1 patients are little bit difficult to treat. They are younger age. At younger age, they become myopes, and at least in our patient, we found that they progress much more quicker, much more faster compared to children who do not have a parental history. And these patients at the beginning itself, these patients may respond to higher concentration of atropine. At this point of time, we do not have data to support this, but at least these patients should be considered for low concentration atropine much more quickly compared to type 2 patients who progress slower and they come later in life. Environmental modification should be suggested as the first intervention, as we will do in other children. So if there is no evidence of progression in a patient with minimal risk factors, then it may be preferable to observe these cases and keep them on regular follow-ups rather than starting them on any kind of treatment. So close follow-ups are very, very important in patients where we feel that these patients may progress to myopia, and environmental modifications are the key in all these patients. All these pre-myopes, actually, as Rohit sir suggests, this is the youngest lifestyle disease. So at the end of the day, what is most important is to tell them and to suggest them at an early stage that lifestyle modification is the key, and this may develop into myopia, and then it would be difficult to go back. So whatever myopia comes, whether it is 0.5 diopter or 0.75 diopter, it cannot be reversed back. So that we have to tell them. The good thing is that if parents are myope, they do understand it much more quickly compared to type 2 ones, where there is no history of parents having myopia, and so they do not come up very quickly, and they feel that this may not progress because at this point of time there is no myopia. So that's all regarding pre-myopia, and this is what we do for pre-myopes between 6 years to 10 years of age. So thank you so much for the opportunity.
Thank you so much for the extensive, detailed talk, Dr. Jitendra. So we have so many questions, I'm pretty sure, because this is the new window that everybody is looking at, and I'm pretty sure that everybody is seeing pre-myopes. One recently faced scenario I would like to ask, there are very anxious parents, especially if the elder sibling is having progression or we are already on the treatment. So what is your approach to handle the younger sibling, and how do you go about it when there is already risk factor in addition?
See, I would again reinforce that you have to see the data whether he is losing his hyperopic reserve and whether he is quickly moving towards myopia. In the absence of any progression, you can't treat progression. I mean, whatever it is, however tempting it may be to treat these patients, you have to have data. You have to have the patient on board. You have to record everything. So it is very, very important to tell these patients that sibling is having myopia. And this is a good time to tell them that you should be aware that he will lose his hyperopic very quickly. And so we have to tell them that without any treatment, if he just changes his lifestyle, there's a good chance. You have already seen your sibling is having myopia. And this is the time, it's a good time that if he changes his lifestyle, at least he will not develop myopia, number one. Number two, even if he develops myopia, it will be delayed at a later age. And so overall risk of developing high myopia would be less in these patients.
Thank you. Anybody?
Jitendra, it's very wonderful lecture. Of course, we are going one step further and treating pre-myopes. I would like to go still further. Maybe in near future, if, for example, amniocentesis is required or say corneal villus biopsy is required for other systemic reasons, do you foresee any validated markers to,
No, sir.
diagnose myopia and treat that? Do you foresee that?
No, sir. I feel it is a lifestyle disease, so we have to understand that so
Yeah, I know.
myopia may progress, myopia may not progress. We are not treating myopia, we are treating myopia progression.
Yeah,
So we have
yeah,
to let the kid, come out of the mother's womb and see whether he is progressing or not.
yeah. I just wanted to drive home the same message. Thank you. Thanks for your
No,
answer.
Dr. Valambe, you have a very, very interesting thing because in diabetes, they are talking about,
Yeah,
prenatal programming. So theoretically, the concept I think is valid for every lifestyle disease, and that is why we need to understand this, that myopia being a lifestyle disease, all children. So we've come across siblings with one being myopic and the other being
Not.
absolutely normal. So
yeah,
it's probably they sharing the same environment. So likelihood is that a lot of personality and a lot of individual susceptibility does make a difference. So I'm not really looking at prenatal diagnostics because yeah, in diabetes they talk about the development of the Langerhans cells and
yeah,
the other development of the endocrine tissues, but there is hopefully some time in the future we may get some blood or some other tests which may hopefully be non-invasive that may help us to predict. So besides the risk factors, there is a susceptibility, natural susceptibility. So we know that myopia is an interplay between the environment with the genetic susceptibility. So if we can identify those children who are genetically susceptible and do the environmental modifications early, it's probably, as Jitendra points out, the best intervention for pre-myope. So identify at-risk group by their genetic makeup as well as their environmental risk factors and try to interplay with the modifiable risk factors to reduce myopia
yeah.
development. But
And this,
I think
yeah.
you're way ahead of most of us ophthalmologists.
Just
And
one question. Yeah, one question. Sorry, madam. Please go ahead.
hyperopic reserve charts, Jitendra.
Yes, ma'am. Sorry, I didn't get the question. I'm sorry, I missed out. Yeah.
These hyperopia reserve charts,
Yes, ma'am.
where are they available?
That one is available on the NICER website, or I can share the article maybe in the group, because this is actually the original study was published by Chen et al. In 2024, and NICER, the North Ireland group, also they sort of did the similar work, and it is there on their website, and it has been validated right now only for UK children. We have collected some data and we are validating what is in our clinic, what is the scoring system and how robust it is. Just one point I wanted to make, that all this talk about pre-myopia is only as I presented in my presentation, it is only to make sure that people are aware that these children will get converted to myopia, and not truly about treating pre-myopes, because we have to find out who is progressing, and only then we can really, because it's a double-sided thing. You cannot treat something which is not there. It is difficult, and there are very few patients who fall into the criteria where you can actually treat. So if you see the sample size which we had only 30 children.
Yeah. Now, this one more question to Dr. Sujata, madam. Are you there, ma'am? Dr. Sujata?
Yes, yes.
Yeah, because you are seeing so many patients in government settings. So are these parents accept the idea of treating pre-myopia?
No, that's exactly what actually I was also going to highlight. When we actually do counsel them, it just adds a lot more to the anxiety. So we have to then start dealing with the problems of anxiety more than the refractive error. So if you notice it, whenever we even tell a parent even if a child has a phoria and atropias, and when you're going to tell them that these are the things they are having and we need to, work them up for it, the mothers are totally taken aback. No one likes that, your kid is having a strabismus, or, you need to get them self-checked. So it's always a denial. So I think a lot more needs to be done at the level of pediatrics, more than the pediatric ophthalm, because every time the kids come for the parents bring the child for their immunizations or any other checkpoint. Whenever a child is brought to the hospital or clinic, anywhere, I think we need to be in association with the other streams as well, wherein we can do this kind of awareness at all levels.
Thank you. Now, the discussion is quite interesting, but I think we'll spare it for at the end. So let us go to the third talk by
Yes.
Dr. Abhilasha. Over to you, Abhilasha.
Let me share my screen. Is my screen visible?
Yes.
So, hello everyone. I'll quickly go through the presentation that can a pair of spectacle help control the myopia? I'm Dr. Abhilasha. As we all know that this is a multifactorial disease, and Dr. Rohit Saxena has already elaborated on the multifactorial approach, and hence there are multiple options for management also. And hence there are theories of myopia progression coming like feedback emmetropization, accommodation lag, dopamine and scleral biomechanics, and most important, peripheral defocus. So we are going to see this, what is peripheral defocus theory. So let's get to the basics. We all have seen on the MRI that more the hyperopic eye it is of oblate shape, and more it becomes more and more myope. We can see this posterior conical shape. So because of this shape of high myopic refractive error eyeballs, something interesting things happen here. I'll go through next slide and we'll come back. So this is the image in uncorrected eyeball that definitely central rays are focusing ahead of the retina and peripheral rays are, few rays are in hyperopic defocus, that is they're falling behind the retina. But what happens when we give single vision glasses? What do you mean by single vision glasses is what we routinely prescribe when we are not prescribing any myopia control glasses. So routinely what we prescribe is single vision glasses. So what they do is central rays are perfectly falling in focus on the retina, which we all want, right? But what happens to the periphery, there is increased shifts of focus behind the retina. And hence all peripheral rays get focused behind, and that becomes the signal for this peripheral rays and peripheral sclera to grow. So that means that sclera wants to grow so that eventually it achieves the clear retinal image. So peripheral hyperopic defocus gives a growth signal to peripheral retina, and hence all this, once you give peripheral myopic defocus, that is all this DIMS and Holt glasses which work on defocus theory, they create this myopic defocus so that peripheral rays are focusing in front of the retina. So let's elaborate a little further that what is desired. Desired is we want central rays to be focused nicely on retina, but definitely peripheral rays should be, there should be a myopic defocus. That is the ideal condition. So what we thought versus what we found, there are few assumptions that we have to reconsider. We all used to believe that growth of the eyeball is fovea driven. And that's what we learn in our residency or med school. But that is, now it has been proved through research and animal studies that it is the peripheral retina which influences the emmetropization and growth of the eyeball. So there are a series of studies by Earl Smith 3 that in 2007, we got the first paper that peripheral vision can influence eye growth and refractive development in infant monkeys. So what they do is out of two eyes, one eye, fovea they laser ablated. So now that fovea is not in question, and still they use the other eye as a control eye, and still it progress. So look at the conclusion they have mentioned. On the other hand, unrestricted central vision is not sufficient, and the fovea is not the essential for emmetropizing responses. Effects of foveal ablation is the same, and optically imposed hyperopic defocus in these monkeys, infant monkeys, the periphery can produce central axial myopia in infant monkeys, which can be extrapolated for the children. So tell me again why I need to know all of these things of physiology. That's because all the current myopia management spectacles or treatment theories are largely based on this peripheral defocus theory and peripheral refraction. So how do you measure it? So it can be measured through a machine that is open field refractor. which is just like our routine autorefractor, but it has this transparent, patient can see through it. And then you can ask patient to look nasally and temporally, and you can take a measurements. But as considered as everybody cannot have this machine, we have to go for the manual ones. So this is the retinoscope, and our own esteemed speaker, Dr. Jitendra Jethani, has innovated a nice tool so that this tedious job becomes easy. That what it is that in residency we all learned that you have to do central diffraction and do not do off refraction, right? Off axis. So here exactly it's ulta, that we have to do off axis, that patient central, nasal and temporal 20 degree, 30 degree. So in 2008, there was paper published that how do you do it? How do you measure it? Either you move or you ask patient to move. Is there any effect of eyeball movements or extraocular muscles if patient moves? So it has been proved through this paper that both the measurements are same. So you ask patient to sit in front of you. Either you can move nasally and temporally, or you can you can move the chair nasally and temporally. So to summarize, there are two options like glasses and contact lenses. We'll be speaking on glasses. So we know these options: single vision glasses with under correction, progressive addition lenses. It's there since ages. But now with the recent guidelines and research studies, we have realized that what doesn't work and what works. So single vision glasses with under correction is like a big no. Progressive addition lenses has specifically indicated in like accommodation lag or esophoria. What definitely works is defocus glasses and contrast alternating glasses. So there are four options like DIMS, defocus incorporated multiple segments, highly aspheric lenslet, that is HALT, diffusion optics technology, DOT, and cylindrical annular refractive element, that is CARE. Coming to few technical details about the DIMS, here we can see that there is a central zone which is clear of 9 millimeter, which is for distant refractive correction. And there are around 400 these defocal segments. If you enlarge this, you can see each the segment is 1.3 mm and creates a myopic defocus of around plus 3.5 diopter. And this is how it creates two planes. One is on the central retina and the peripheral myopic defocus, which slows or slow down the progression. This is the honeycomb treatment zone, which is like 33 mm around that 9 millimeter zone. And you can see when patient is wearing also with the help of batter. Coming to the next technology, that is HALT technology. So here it is the same, but it creates a volume of defocus. So instead of a single plane or two planes, it creates a volume of defocus, and it has this 11 rings, which creates this volume of defocus. Coming to the DOT technology, so this is not related to defocus. This is very different than this. So it has been suggested from genetic points of view also that there is empty and full cone or abnormal signaling of adjacent cones, which is leading to the axial elongation or increase in myopia. So this DOT technology is working basically on abnormal contrast signal. Next is the CARE, that is by Zeiss. So these are the basically cylindrical annular elements. They create high order aberrations. Segments like both normal zone and treatment zone. So when they published, first year they published CARE and the second one was CARE-S, and definitely they realized that the CARE-S is better. So together in the form of rings which go from center to periphery, put on the front surface, it creates a myopic defocus in the periphery. This is the central zone and this is the functional zone, as we can see. So what about the efficacy? Where is the evidence? So there are multiple papers on the DIMS. Initially, it was not from the Indian study, but nowadays we have eventually a good data on DIMS and HALT, both the lenses. And it has been proved that it is around 60 to 70% slower progression rate, and they are effective. So as you can see here, that first is spherical refractive error progression and second is axial length progression. There is no significant difference between the outcome data of these two lenses. So these are the few specification of DIMS and HALT lenses that you can prescribe from -10 to maximum cylinder -4 and spherical equivalent of -12 in HALT. correct me if there are any updates regarding this. Coming to the side effect profile, first of all, there was a study done only for not the efficacy, but the side effect profile of these lenses. So comparison of myopic progression on the quality of life. And our own Dr. Sumita Agarkar has recently published on DIMS also. So what are the results? That they work fantastically without negatively affecting their overall quality of life. What are the challenges? There is peripheral blur during adaptation period. So a lot of people complain that there is initial days, 1 or 2 days or first week, there is peripheral blur when they see through that treatment zone. Because it is very scratch prone, few parents mention that we cannot have extra pair. Definitely cost is also the factor. Difficult to repair, availability in selected location. These are the challenges, but it works beautifully because there are benefits also. It is least invasive. Anyways, child has to use glasses. Regardless of modality of myopia control method, child has to wear glasses. So child doesn't feel that he or she is on any particular treatment. Parents found these spectacle lenses to be less cumbersome, effortless to use, usual looking, and hence the better compliance. Hence can be used as a primary therapy as well. What about secondary therapy? What is secondary that we can add on to the existing therapy if there is non-responder or slow responders? So whether this therapy is safe. So combined therapy, that safety of combining DIMS glasses or HALT glasses along with atropine, whether it is safe or not, there are studies and it has been proved that they are safe to use. Rather, it gives additive synergistic effect and there is better control. So Dr. Jitendra Jethani also has published that 10 cases where they were non-responders and on the atropine, and then they added this DIMS glasses. What we already know not to undercorrect myopia. By this time we have realized, but the most annoying part of academic writing is knowing the thing but looking for other paper to say it for you. It's just like saying the bread is soft, but you have to say according to Baker 2001 bread is soft. So why not to undercorrect myopia? Because there are studies that undercorrection of myopia enhances rather inhibits the myopia progression. So we definitely don't want progression of myopia. Other thing we knew is this myopia management option don't work in other refractive errors like pure astigmatism cases. And again, to prove there are studies to support it. Because these glasses work on creating myopic defocus, and in astigmatism, it doesn't involve axial elongation. So theoretically also there is no benefit. So what doesn't work? Undercorrection, pinhole glasses, blue light blocking glasses, bifocal glasses, progressive addition spectacle lenses, as I said, very particular indications are there, and rigid gas permeable contact lens. So these are the guidelines to suggest that let's stop doing what doesn't work probably. This is our experience. We looked at our data that out of 120 patients, 70 patients opted for myopia control. Out of that, 52 patients are on only DIMS, 18 patients are on combined therapy, out of which 48 patients remain stable even after 2 follow-ups at the treatment, and 12 still progressed, and we had to add another modality, that is low-dose atropine 0.01. Coming to, I would like to share 1 or 2 cases. This is the first child, 7 years old boy, who is avid reader, mother is highly myopic, father emetropic. So this was the risk of progression in his case. So look here that initially when he visited us, it was minus 1.5 and minus 2.25 in left eye. We advised lifestyle modification and single vision glasses. After that, child was stable, but in December, child progressed. And at that point, we prescribed glasses, and afterwards, child is stable. This is the graphical representation of the same, that initially we advised lifestyle modification and counsel the parent regarding options, and they wanted to rethink and come back. When on next visit, we found there is a rapid increase, then we still added the DIMS glasses, that is peripheral defocus glasses, and henceforth the child is stable. This is similar for same child, excellent prolonged progression voltage. Coming to the second child, 9 years old girl, father myopic, mother myopic, presented on September 22 with the best corrected 6.6 and minus 3.25 of cylinder. This was the risk of progression. That near activity was high. Again here, as you can see that when initial 2 visit, child was stable. In January 24, when we realized there is a progression, we added low dose atropine, that is 0.01%, and child came back. Even after that, though there was no significant, still there was a progression. Then we had to add second modality, that initially lifestyle modification. Then afterwards we added LDA, it was on OD 0.01, and then we suggested that we can still go for BD, that is twice a day. But child was already not compliant for even single dose, and hence parents chose to go ahead with the DIMS glasses, and hence afterwards this is his third visit and child is stable. Similar for axial length Premyopia. So I would like to share few guidelines suggested by AIOS, impact and WSPS. So identify true axial myopes, map the risk factors, pick progressive myopes, advise appropriate myopia technology. This is the AIOS guidelines formed by esteemed speakers, and everybody was involved in this in 2023. Here is the most commonly asked question: what all things you do in your routine protocol? So there are must do things, good to do things, and exploratory things, which sir has nicely compiled. This is the WSPS guideline. You can scan this QR code and you will go to 2023. Recently, in last week, they again published the recent guidelines. So things to apply, study to clinics is when not to treat is pathological myopia, pure astigmatism, no documented progression. And let's avoid undercorrection, let's avoid prescribing without cycloplegic refraction. Identify true cases, document progression, both for refractive error, that is spherical equivalent, and axial length. And lifestyle modification is always the first line mode of management. Hence, keep on emphasizing healthy lifestyle on every visit. And remember, it's a long journey. Thank you.
Thank you, Abhilasha, for the wonderful lecture. Just one question. For so many other reasons, for example, the glasses are broken, the DIMS glasses are broken, or the parents are not able to afford the financial reasons. Do you find any rebound effect if they are not using? What's your protocol for that?
So honestly, in my whatever tiny experience in front of all other speakers, but I have not, I read through this, because your best teacher is like parents. They keep asking you so many questions, and eventually they will say, what would you choose for your own child? And that time you have to go back to the books and read a lot. So guidelines also suggest that there is no rebound. So we have some patients that because they are not affording, or they did not get at their local vendors, they stopped using DIMS. And we saw if the child is having lifestyle modification in place, then there was no significant progression, as in no rebound progression. Rebound, I would say there will be progression because child is not on any myopia control. So it is going to happen. But rebound, as in we see as like atropine, there is no fast progression. I have not seen. But definitely there are 6 to 7 kids that they missed the follow-up and they had stopped using the DIMS classes. I would like to hear by Dr. Rohit Saxena and Jethani sir, what is their experience?
So yes, most studies have said that opticals do not have as much rebound as we talk about in atropine. And one of the reasons we have felt that rebound is there in atropine is because of the fact of anterior segment compensation that happens because of the atropine that you're using. So even if it's low dose cumulatively, it does cause certain amount of cycloplegia. And that is why probably the axial length and the refractive error change on atropine therapy does not correlate. So all studies right from ATOM 1 have said that there is lack of correlation between the two, although you expect that it should happen because myopia progression that you're actually talking about is axial in origin. But it does not, so possibly because of the anterior segment bit of cycloplegia. And once you stop atropine, the tonus comes back and that increases the myopia. So part of the rebound and the part of the efficacy that we claim to be with atropine is possibly that. And because this factor is not actually applied for or applicable in opticals, it is believed that you don't get rebound, and most studies haven't shown adequate rebound. But unfortunately, I think we have had this intervention for not such a long time that we would have at least a year or more of children off glasses, or a large number of them to be able to say with concrete. Just having a few children who are not compliant may not give us the accurate picture of the rebound or not. So I think data is yet to come, but the studies that have been done do not show significant rebound. But yes, we're still awaiting good hard evidence.
I have one.
Jitendra, your take on it? Yeah, sorry, sir.
Actually, this is a very common Dr. Abhilasha's second case, which he presented. We start with low dose atropine, which has to be continued for 2 years, but the compliance goes down. I mean, many of my patients, they don't actually put atropine at bedtime for 2 years. So after say 3 or 4 months, they just simply stop it. So I have got patients who have got rebound or increase in myopia or progression of myopia after that. In many of these cases, I switched over to these DIMS glasses by Silor, and that has also been found to be equally effective in myopia progression. So actually, definitely the compliance for glasses is much better than what it is for atropine, and many of these non-compliant atropine patients can be switched over to DIMS. I think the second case was something similar to that.
Just a couple of
This question
cautions for optical intervention. I'm sorry. Just a couple of things. I think whenever you're prescribing opticals, you need to tell your children. Like in atropine, we talk to them about allergies and whatever, however so remote. I've had a couple of patients or very perceptive children who are able to appreciate that slightly constricted field, because 50% of the light from the periphery has been cut off now. So the moment they look from the side of the glass, and we often do, they they immediately realize that the quality of image is poorer. So you need to tell them. Some very perceptive children came back with dizziness and things like that, but essentially I haven't had any child who has had to discontinue glasses. The other thing is, I always tell them, have another pair of single vision glasses, because we want them, we encourage them to go out and play. And these highly expensive glasses, if they get broken in a rough game of football, can be a heartbreak for the parents. So
They do
you
compensate
need
for
to
the
tell
first
them.
year, actually. I mean, at least SLR.
Yeah, but they don't compensate for breakage. They only compensate for if the power
Progression.
increases beyond 0.5 diopters. So breakage, they don't compensate. So if it increases, so essentially they will accept that yes, there has been a failure to the technology that we are providing, and we hope that you continue to use them, and maybe they will be effective in the next 6 months or whatever. But these are important things, and we tell them. Very perceptive children do appreciate that there is a reduction in the quality of image, but they over time learn that when they look on the side, either don't do it for too long, or they move their head. So these are important things, which is important, should be told, kind of guided to very perceptive children.
Just a quick question. I just want to know, when we are suggesting the outdoor activities, do we also consider the nature of sports that the kid plays before you start prescribing the DIMS? And what are the children's reactions to the restrictions or a better functioning in the game after we start that?
So I don't restrict. I mean, I'm glad if they have any interest in outdoor games. It has to be encouraged. So that's why I said, I always tell parents that have a single vision glass which the child should wear when he goes out. There are no studies that have given a duration for which you need to wear these glasses, but at least one, again, just like outdoor activity, you feel that there has to be a particular duration for which these glasses have to be worn during a day. So about 8 to 10 hours is considered an average. So at least 8 hours they have to wear. But always children should have a single vision glass so that it reduces the risk. So that is why I don't discourage any kind of outdoor activity, sports, or whatever the child may be on. The only precautions are what a normal child with glasses should be having. And I encourage them that the single vision glasses should be kind of sport friendly. So polycarbonate lenses with a sturdy plastic frame should be the single vision glasses, and the child should be encouraged to go out and do whatever he likes. provided,
Does
of
it
course,
take
there are
some
no other
time?
risks.
Sorry, does it take some time for them to transition to the normal single vision glasses? I mean, are they able to adjust to the single glasses with the tips? I mean,
Yeah, for that period, yes. I mean, they usually do not have, like, obviously the single vision will be better than the these peripheral AD glasses, because like I mentioned, in the peripheral or AD glasses, some perceptive children, if you look through the edge, you'll appreciate the slight decrease in the quality of the image that is formed through the
no,
periphery.
I'm
So
asking the other way around. If they go
yeah, so
from
they don't. I
again,
mean, I haven't had any child who has come back to because of that. The original, yes, the initial problem of adjusting to these kind of glasses, but the reverse, no, all are pretty comfortable, and they do wear single vision glasses for a little while, like going out. So it's not that they'll never wear. But like I said, I haven't had, or maybe I haven't asked for it. I assume that, so I don't ask for directly. I ask for
because
problems with
Yeah,
the
the
other
interest,
way.
because the children are very
yeah, the
intelligent. I
discussion
mean,
is
they
quite
would come up
interesting,
with
but I think
specific issues if they do have. So I think we should also see the other part of it. Yeah. Thank you. Yeah.
yeah, we'll have the last speaker, Dr. Siddharth, and I think we'll continue the interesting discussion at the end. So I request Dr. Siddharth to take over and start his lecture.
Doctor, please unmute yourself also. Good evening, everybody, and thank you, Dr. Abhilasha and Dr. Piyush, for this invitation to speak on this wonderful program with all the other friends of mine who are there in the panel. Good evening to everybody. This is right about the time when people are supposed to put atropine in their eyes and go to sleep. And so I'm going to speak about insights into therapies for myopia control. My talk is basically sharing things that I have, observed in my practice over the last so many years that we have been trying to control myopia. And so the atropine story is just like a soap opera, and it's been going on for the last 60 years. You wouldn't believe the first time people discovered that atropine can control myopia was way back in 1966. So next year we will be celebrating the 60th anniversary of myopia control, and it keeps coming back every 10 years, I guess. So it got talked about in 1966, then got forgotten. Then in 73 again it came back, then got forgotten. Then it came back in 1985, got forgotten. And then in 1989, then back in 2000, and then on, once the myopia incidence started increasing in the eastern part of the world, is where people started really looking at all the things that have been done in the past and see if something could be put into practice. And that is when those landmark papers of Atom 1, Atom 2 came, which were the blockbusters, I would say, and made atropine a superstar. But atropine has been making guest appearances all the time. So just like any soap opera, there is a lot of suspense. We still don't know how it works. There is happiness and in sadness, happiness in patients where it works, and sadness where patients where it doesn't work. And there is hope that one day it will help us to control myopia along with other interventions. But there is also despair when we come along studies like Atlas, which tell us that after you stopped atropine, things just went back to what they were. So, this is what we have also observed in our practices, where what we think we know so far, that atropine indeed retards myopia progression. There is absolutely no doubt about it. And Atom 2 showed that even very, very dilute atropine has some potential to stop myopia progression. Although none of the studies after Atom 2 have shown the efficacy of 0.01% to be as much as what was claimed in Atom 2. Yes, it helps somebody, but there's a large population of people who do not get help with 0.01% atropine. We also know that it is without any serious side effects, right now, millions of children in India are on atropine eye drops, and I am sure none of the panelists here or can think of any serious adverse side effects that they would have seen in any child they would have prescribed diluted atropine. So attempt 2 left us with some unanswered questions, wherein although atropine 0.01% showed some efficacy in controlling myopia, it did not show any efficacy in controlling axial length, which was a paradox in some sort. And that brings us to what we are not sure about. We postulate that atropine works on M1 and M4 muscarinic receptors and inhibits the signaling of the T focus that forms on the retina and causes the sclera to elongate. And so in that retina to sclera signaling is where probably atropine works. It also works to retard the laying down of the matrix that forms the sclera. We are still contemplating which dilution is the best to be used. We are not sure about dosing. We are still debating whether to taper it or not, whether to give it for 1 year, 2 year, till 14 year, 15 year, or 16 years. There are different schools of thoughts for different age groups. We are also working on some delivery systems, and very long side effects are still not known. What happens to these children after 40, 50 years? Will they get early onset cataract? Whether they have a macular degeneration, whether they'll get glaucoma? We don't know, because it's only been used in practice for the past 5 to 6 years. And because it has got a lot of patients who are not responding, so we also are looking into combination therapy. So there's a lot to learn still about atropine. Although we are still using it in practice, we are learning as we go. So earlier we used to talk about the ATOM 1 and ATOM 2 study. Now we talk about the lab study, which showed that 0.05% atropine is the go-to concentration, which is twice as effective as 0.01%. In this study also 0.01% could not show the same benefits that were shown in ATOM 2. So ATOM 2 was a sort of outlier as far as the effect of 0.01% is considered. And all of us do feel that higher concentrations are required in most children, although a minority of children do respond to 0.01%. In most children, we need to step it up. Pupillary dilatation and reduction in accommodation amplitude is also very less as comparable and is comparable to 0.01%. So 0.05% is twice as effective, but not twice as bad. So because most of the effects and side effects are dose dependent, and even rebound is dose dependent, it gives us a sweet spot where things are strong enough, but the side effects are not bad enough. So let us look at the comparison of different concentrations in LAMP as far as the side effects are concerned, because that is what we should also look at when you are trying to give therapy for 5, 6, 7 years. So as you can see in 0.05%, photophobia is seen in around 8% people because the pupil dilates by more than 1 millimeter, which is almost twice as much as what would happen in 0.01%. So as we start using 0.05%, we are going to get more patients who would come back and tell us that they have photophobia or they are intolerant to bright light or outdoor activities. So that is one we need to keep in mind when we switch from lower concentration to higher concentration. This particular slide is what I would like to bring your attention to. In this slide, it has shown that what percentage of people do not respond to atropine. While in the last so many years, we always talk about atropine leads to 50% reduction in myopia progression. Even in LAMP study, 30% of patients who are on the good concentration, that is 0.05%, continued to progress for more than 0.5 diopters per year. And for 0.01%, it was more than 50%. So don't be surprised when patients come back to you in your clinic and they are still progressing. Even in the well-controlled studies where compliance is good, people will progress. So non-responders to 0.01% were 18% in ATOM2 study and almost 28% in LAMP study. So you see almost 25 to 50% of your patients may not respond to atropine. So don't be surprised by that. It is also, so if it works for your patient, fine. Otherwise, think of switching on to something new like myopia control spectacles. So we also need to be cautious about what we are using, as I have already discussed, that it may lead to cataract, macular degeneration, presbyopia, glaucoma over 30, 40 years. We still don't know. So if we can think of a better substitute to prolonged pharmacotherapy, just like myopia control glasses or maybe orthokeratology, uh, and if they are found to be equally efficacious and with more people using it, I'm sure the prices will also come down. Then I think that should be the way forwards. Whether controlling myopia itself, we have to question whether the goal of controlling myopia will actually help us control the complications. We still don't know whether retarding the progression of myopia will retard the incidence of lattice in a particular child. In private practice, I'm sure you have seen lattice in children who are having myopia even 2 diopters. And then there are children who have myopia 10 diopters with no lattice. So the retinal changes, will they become less if you control myopia in a particular child, is something that needs to be studied. Again, I am seeing more and more children being put on atropine the moment they are diagnosed, even children as young as 2 years and 3 years. I personally believe that we should withhold it from children who are 4 years and 5 years because it may just interfere with the process of emetropization. As we all know that at birth and immediately in the first 2-3 years, children may be hypermetropic, astigmatic, or maybe myopic also. And this, with the process of emetropization, can become normal. So there is no point in jumping into treating myopia progression in very small children, very young children, when the eyeball is rapidly undergoing changes. Recently, 0.505% atropine was launched commercially by Antort Pharma, and that is a very good development in this field because all over the world, even in Singapore, people have moved to higher concentrations of atropine, and very less number of people are using 0.01% atropine. Most of the countries, the starting dose is 0.025%, and the non-responders are given 0.05%. So now with that in our armamentarium, I'm sure it will help treat the non-responders, which are very high in 0.01% group. I also feel that commercially 0.025% should become available so that we have multiple concentrations and we can tailor make treatment. Probably start at a higher dose and then taper it to a lower dose. Personally, I use twice a day atropine quite a lot in my practice. Almost all of the children who are put on once a day atropine get switched on to twice a day atropine in the next visit. And I find that twice a day atropine has much more effect than once a day atropine. It brings us to the question that does 1% atropine, which is the strongest agent known, still have any role? Now, in all the studies come across in the last 50 years, which have studied 1% atropine, it just gives you excellent results. It stops myopia in its tracks, but the only problem is it gives you severe photophobia and paralyzes your accommodation, and you are dependent on photochromatic progressive glasses. But then a very interesting study was done in China in 2020, wherein once monthly atropine given alternate month to each eye was shown to retard myopia progression, which is excellent. So, even if one eye is blurry, the other eye is working in 1 month, and the other for the first 3-4 days when the atropine is acting, and the other eye is given the drops the next month. And that way, still they showed a lot of reduction, almost 70% reduction in myopia progression. So if in future we might also have a strategy where atropine doesn't need to be put every day, maybe weekly, some concentration, higher concentration maybe need to be put weekly or monthly, and then that would suffice and have the same kind of effect, because we don't know that once it binds to the muscarinic receptors, how long it stays, how long can it, kind of exerts its influence over the whole process, and when does it get washed out, and then so right now it's we are empirically giving it once or twice a day, maybe giving it once a month or once a week on a higher concentration, maybe the future. Now, a recent publication by the group which published ATOM 1, ATOM 2 trials, wherein they studied the children who were taken off atropine after they had reached 18 years of age. Although the data itself was a small subgroup of all the patients who were studied, it did show that the patients continued to have slow rebound even if the atropine was stopped after attaining visual maturity. So that leaves a big question mark when to stop atropine, because whenever you stop atropine, and ultimately if the effect wears off and the rebound slowly takes it back to where it would have been if you would not have been using atropine, then it defeats the entire purpose of treating myopia progression with atropine. So this is something that we will have to look for in future. What happens to these children once you stop atropine? Do they continue to progress or not? In 2018, we published the first myopia control guidelines using atropine, and which was now we have more refined guidelines from WSPOS and AIOS. But most of them agree that if myopia is progressing for more than 0.5 after a year, then you should start myopia control, and usually start the myopia control whenever you document the first sign of progression in children as young as 5 years, and you continue it for at least 2 years before trying to stop it. The current recommendation is don't stop it suddenly, kind of taper it, maybe give it twice, once in 2 days, then once in 3 days, then once weekly, then stop. This varies from person to person. Do not judge progression in the first 1 year because it takes a lot of time to start showing some effect. It should only be used in simple myopia, and should not have any other ocular or systemic comorbidity. This is something you have to remember, because I've seen a lot of children being put on atropine who have congenital high myopia, pathological myopia, ROP-related myopia. Occasionally, the astigmatism patients are also put on atropine, so this should be avoided. People need to know what it is. Only for school myopia. School myopia is when you start going to school, it starts, and when you stop going to school, it stops. So it starts at 6 years, stops at 16 years. That is what is school myopia. And for not responders, maybe higher concentration or combined therapy should be tried. Recently, new trials are going on contact lens delivery systems for this kind of long-term therapy. We will also need preservative-free atropine in future, because the preservatives may itself cause some problems. My personal experience with combination therapy with glasses has been extremely good. The patients who do the best are the ones who are on twice a day atropine and are using one of the myopia control glasses. They show excellent results. So if you have to treat somebody in your family, I recommend you give them twice a day atropine and the atropine control glasses, and they would probably have very good response to treatment. So the misunderstood use of myopia control is that it is not to stop reverse myopia. It is to slow progression. It is not even to stop progression. So somewhere this message gets diluted. Everybody thinks that once you start therapy, myopia will not increase at all. Myopia will increase, but it will only increase at a slower rate. Thank you very much. If there are any questions, we can take.
That was a very wonderful and thorough talk with Dr. Siddharth Kesarwani. So I would like to ask a couple of questions, but before that, I would request Dr. Prachi Agashe to comment, and she has one question for Sir also.
Thank you, Dr. Abhilasha. So excellent talks by all the panelists. I would probably go back to the last talk on your talk of the lenses and special glasses. I just wanted to bring up this topic as to, is there any time period after which we can say, okay, that we can stop the defocus lenses and switch to normal lenses, like at least the way we do for atropine, like if there is stabilization for over a year or so, we want to taper and see what's happening. So do we do that even for the defocus lenses, or we just continue till around 15, 16 years of age?
So at present, I have a follow-up of at least 2 years with the DIMS which are stable. And yes, a lot of parents, when you counsel them regarding atropine, and the moment you utter 2 to 3 years, you have to put their expression changes. But simultaneously, the following question is when to stop the DIMS. I have yet not recommended anybody to stop the DIMS, but definitely those who are on a stable myopia, I have 1 or 2 cases I had presented. That child is nicely controlled on atropine, but now because we have to stop after 3 years, parents are so anxious that now we don't want, she is in 10th standard, and now we don't want anything to progress. So can you please recommend DIMS glasses? So I asked this question to panelists. So because of parents want something to be on, so we prescribe the glasses because it is least invasive. But I think that was a very wonderful question, and analysts may answer.
Actually, there is one the recent study by Essilor that was done in China. They have studied those patients with DIMS for 5 years now, with 5 years follow-up. That is perhaps the longest follow-up of myopia control glasses. And those patients have, they are still continuing on those glasses and they have found good results as far as myopia control is concerned. So even long-term use of these myopia control glasses can be done. That's what I feel.
I'm just asking, is there a time that you would want to stop that? It can be done, I understand, but is there a time period that we want to say, okay, now their myopia is controlled, they are stable, and we just want to switch back to the single vision lenses or like that?
So we would use similar thought processes as we would use for any therapeutic intervention if we are wanting a change. So if I have a child, I've started on myopia glasses on, say, he's 11, 12 years old. And by 15, up to 15 years, 2 or 3 years follow-up, he is stable. I could discuss with the parents that it's an annual expenditure, and if you feel that it's high, we could stop and observe the child for a while, because he's kind of past that age when you are expecting this myopia to increase. That's the only condition when I would be outrightly keen on thinking on stopping these glasses. Younger the child, obviously, the longer the intervention. Unfortunately, as I started in the beginning only, our experience with these glasses in India has been about only 3 years, give or take a bit. So really, none of us have, tried to stop children or get them off glasses and see how much rebound is happening in them. So maybe more data will come as we go, but at the moment, I'm only willing to try this out in older children. And younger children, I would definitely encourage. Like, we've had children on atropine for 5 years easily. So similarly, I do not see any reason why I would, not be willing to consider continuing them for 5 years in a younger child who is at risk of developing progressive myopia.
Yeah.
And
So this
also,
question is for
as
Dr. Siddharth. Sorry.
if I may
Sorry,
just
please go.
continue. So the way Dr. Abhilasha said, I mean, we always come to a situation where we are stopping the atropine, and then till the child, say, I suppose like 12, 13 years, tapering the atropine and wanting to stop it. Will we then shift the child to the defocus glasses as a maintenance to 15, 16 years of age, though the child is stable for the past, say, couple of years? Or we just want to taper and observe, and if there is progression, do we want to do the next intervention?
Why we want to stop atropine? Just a counter
So
question.
suppose the myopia is stable. Suppose the child has been on myopia say, for a couple of years, or say 3-4 years, and the myopia has been completely stable for the past 1 year with the initial length being stable. Then we would want to give a tapering dose and stop the atropine and see if the myopia is remaining stable.
I would like to add on to it, there may be some specific requirements for the teenagers. I mean, they're into that age group when the need for the mobiles and the near work and the other, how their appearances, all those factors play a major role. So are the requirements a little different when they enter the teenage and how receptive are they for these treatments that we are continuing until the age of 12, and then once you have that growth spurt and other requirements different, and how compliant are they to the treatments that we advise? If anyone can just share.
These are patients who have been they have been compliant and they have good control. I mean, these are clinical situations that I think we come across quite commonly. So I just want to know the viewpoint of the panelists as to how do they go about it, as to, like, suppose if the child is on monotherapy, well controlled, and we are thinking of tapering and stopping one treatment, do we want to add a second treatment as an intervention even though the child is stable, or we are just going to observe for a rebound and then start the second intervention?
You would definitely look for evidence of rebound before I would think in terms of discussing. So we've had children whom we've tapered atropine and stopped, and they show an evidence of rebound. And parents by that age are more willing or feel that the child is maybe more comfortable with
Yeah.
optical spectacles, or even some cases we have now getting a little bit of an experience in orthokeratology also. So if I see rebound, I plan that. I would not at the moment think that opticals would be a way to substitute atropine, taper and stop. So both are equally effective, very good interventions. So, it would be either or for therapy rather than for tapering.
The discussion is quite interesting, but I think because of the want of time, I'll just ask one more last question to Dr. Siddharth. You already mentioned it, but I just want to drive home the point, because we see a lot of prescription on ROP babies, pathological myopia, getting atropine drops. So what's your take on it, Dr. Siddharth?
So right now it is indicated only for school myopia, which is primarily axial and Oriental.
Yeah.
So it has got very specific indication. It is not for
Yeah,
all
I want to
myopia.
drive home the point. That's why I asked you.
There are a couple of questions in chat box. I think Dr. Jethani has already answered one of that in chat box, and the other question is on proper protocol or tapering schedule for discontinuing the atropine treatment in myopia management. Question was put, I think Dr. Kesarwani has included in his last slides about the
Abhilasha, can you just quickly summarize what they asked, because the chat box is restricted, private.
So the question is, could you please advise on the proper protocol or tapering schedule for discontinuing atropine treatment?
So because we are right now using only one concentration, so you would taper it by reducing the frequency. So if somebody is putting every night, then you will make it once every 2 nights, and then once every 3 nights, and once weekly, and then gradually stop. That is how. And if you see rebound somewhere, then you just roll it back immediately.
And can we have one more question, or it's already 9?
Yeah, just one last question to Dr. Rishikesh, because I know he's working in rural as well as urban population in and near Nagpur. So although we talk about the myopia control glasses, but many of the large chunk of population, they just refuse to use glasses also. So how do you tackle this problem? Unacceptance to glasses, to using myopia control glasses,
You
and
mean
the
use
proper
of
therapy
the
bringing
normal glasses
pre-myopia.
or use of the myopia control glasses?
Any
Because
glasses, because many of them are not ready to use normal glasses. I'm just talking of the other extreme. So how do you tackle that?
Actually, the compliance for normal glasses for myopia is comparatively good, because the moment the child is able to, I mean, compared to hyperopia, that is the question. Definitely, children are able to see better. They can notice the difference with the myopia glasses compared to a child who has hyperopia. So I feel compliance is actually not a problem. And I mean, this is my personal experience. I have seen urban children and rural children, even for amblyopia treatment. The compliance of rural children for amblyopia treatment and for even wearing a spectacles is much better. They simply follow their parents. They don't have any questions asked, compared to urban children who have a lot of questions and doubts, and they keep on having second opinions here and there. So I feel for
Yeah.
rural children, it's much better and easier to manage.
Okay. Okay. And one last question for Dr. Prachi, because I know you're working a lot on ROP babies and the syndromic babies. So the progression of myopia in these patients, and how do you, manage such patients and their parents as far as myopia is
So,
concerned?
yeah, so basically, I do not give atropine for myopia that we see in
Yeah.
preterm babies. And to very aptly put it, so basically, the myopia in these kids typically increases in the first couple of years, say 2 to 3 years, and then most of the time it stabilizes. And sometimes when these kids grow older, it also tends to sometimes reduce. So again, wherever possible, whenever the child is around 3 4 years of age, we still get a biometry done to document that this is not an actual myopia, but it's related to the prematurity related myopia.
Okay.
And otherwise, so that's so no atropine, I mean, no myopia control strategies. It's just proper correction of the refractive error that is required in these kids.
Okay, great. It's a very interesting discussion, but we have to stop because of the want of time. So I would like to definitely acknowledge the MOS office bearers, Dr. Shirish Thora, Dr. Viral, Dr. Sean Chinsole, Piyush, and Dr. Sumit. So over to Piyush for the concluding remarks and for vote of thanks to Dr. Sumit.
So, fantastic, absolutely fantastic. One of the nicest parts was somebody who's in Mumbai has unmuted, and there's a lot of background music from the road, and that just brings us to reality, So, but excellent. I've been receiving a lot of messages. Thank you to everyone, especially Rohit sir, who I know you must be really tired. And despite the fact that you've been there throughout the meeting and sharing all your inputs, Sid sir, but I mean, I'll leave it to my brother in arms, to Sumit, to give the vote of thanks to all of you all. But not before saying thanks to Sunil ji for being there over here and to Entod. Over to you, Sumit.
Good evening, everyone. It was very nice to listen all this, because we know other than anti-VEGF, where there's maximum research and the hot topic in ophthalmology, which may remain hot for a while or maybe forever, is myopia control. And there are so many studies coming up, and all of you very nicely summarize along with the examples. And I think this will be very useful webinar for all our audience. So I'd like to thank our speakers, Dr. Rohit sir and Dr. Jethani sir. It's always pleasure to listen to you both, and we know we have authorities in the subject to talk to us. Then there is no other source needed to clarify our doubts. Thank you, Dr. Abhilasha and Dr. Siddharth Kesarwani, our own MOS team, for adding those beautiful case example and summarizing all the studies. Our expert panelists, Dr. Bhave ma'am, Dr. Sujata ma'am, Dr. Prachi ma'am, and Dr. Rishikesh sir, thank you for your expert comments and the discussion. And of course, our moderators, Dr. Prasad Vaimbe sir and Abhilasha again, for curating this program beautifully well and having those questions. And I first time see a lot of questions on the Facebook, YouTube with this webinar, because everyone is interested. I know for the want of the time we need to close down, but if you would have gone for till 11 o'clock, 12 o'clock, I think still the questions will be keep coming. Thank you everyone for being here. Thank you Entod for sponsoring, and thank you team members for this beautiful
I
platform.
want to add one last thing before we all go. I think we as ophthalmologists, and more so the pediatric ophthalm, in a treatment where when we are writing, continue glasses and continue all that, I think we should include the part of the treatment as to play games, outdoor activities should be as a treatment protocol, so that when they go back to the teachers and the schools, it is at least registered as a very official format of treatment, and they can pay heed to it, and we can work collectively over it. Very nice, great insights. Yes.
Our sponsor, Entod, wanted to play a small video. Kindly go ahead, Mr. Sunil.
Thank you all, and we call it a night, I suppose. Thank you.
Yes. Thank you.